My name's Emma. I'm technically a clinical scientist, but phrases and training is changing at the moment. I'm actually also known as a cardiac physiologist, cardiac scientist. It's all a little bit interchangeable at the moment. I work for the NHS and I work at Portsmouth University's Hospital Trust, as well as being a hands-on clinician, where I am 5 days a week hands-on. I also am an honorary lecturer down at Portsmouth University. So my day-to-day job is clinically looking after patients who may have or may be about to have a heart condition. We help to diagnose that heart condition. As clinical scientists, we make up quite a small portion of the workforce. We're probably about 5% of the workforce as cardiac scientists, but we're involved in something like over 80% of the cardiac diagnosis that go on. If you have a long-term cardiac syndrome, history, diagnosis, so you will run into us at some point. We're the people that you meet that help give you a diagnosis and manage you and give therapies afterwards as well. Right, bear with me while we go for the share screen, which never usually goes to plan, does it? Well, that's a good start. Right, so my case study I'm going to show to you is just something to get kind of the juices flowing a little bit. It's a Monday, it's an evening, and this is really just about trying to get you involved and aware of some of the fun and sexy stuff that kind of happens in the hospital. And this case study is really about being in the right place at the right time. Now, I am going to put a warning up there. This is one of those stories where there is a happy ending, but if anybody's got any little triggers about arrest or emergency situations, this is your warning. So as I've described, I am a physiologist or scientist. We're from a subgroup of people, healthcare scientists. You have doctors, you have nurses, you have allied health professionals, and you have healthcare scientists. I come under healthcare scientist. As a healthcare scientist, you have a minimum of an undergraduate BSc or BSc Hons, and you'll find that actually many people throughout the career can supplement that and actually go on to have masters or PhDs or doctorate equivalents. There's really, the world's your oyster on this. Personally, for me, I started actually with a foundation degree in medical technology. I then went on for the BSc in clinical physiology and then master's modules, and now I'm now doing my PhD at the moment as well. So you can go all the way up the road if you want to. It's an extremely patient-facing job. If you want the job where you're going to be sat at a desk or sat in a lab with a Gilson's pipette, this is probably not for you. You will always be patient-facing. Any interpretation or test interpretation and actually giving treatment on hearts is what we do. It's broadly split into 3 areas. The electrical side of it, so the ECG, the electrocardiogram, which is recording and interpreting electrical signals from the heart and then taking some sort of diagnosis from that, which we can plan treatment on. Implanting and following up pacemakers, which are devices that stop the heart from going either dangerously slow or dangerously fast, and exercise tests. There's lots of uses for exercise tests, but most cardiac patients, if they've got some sort of angina or heart attack, they may undergo an exercise test at some point to see how their recovery is. Then you have the blood supply aspect, which is the treating of heart attacks. So these are your people who have been taken into hospital with chest pain. They don't go to the emergency department anymore. They come straight to us, straight into what's called our catheter lab. And basically, we treat their heart attack. We take the blood clot out of the artery that's causing the problem. And means we're treating heart attacks within about 2 hours from somebody having an onset of pain. Obviously, that means a fantastic patient service. It means that the patient is in hospital a lot less. They get treated a lot quicker. They get their blood supply to the heart restored quicker. And all-round outcomes are really good from heart attacks these days. And lastly, there's the moving structures of the heart that we look at. And that's primarily with ultrasounds, which we call echocardiogram. It's an echocardiogram that's going to be the basis for the rest of this little case study. So that's our 3 areas: electrics, blood supply, and moving structures. So as I said, echo is where I work. and this is going to be what this little case study is based around. It's very quick, it's painless, it's cheap, it's reproducible. The whole world loves an echo. I have an inpatient service at work where I can have about 80 plus people in the hospital waiting for an echo. And we do about, I'd say, 800 a month on outpatients, because it's such a useful test. You can tell so much about the structures of the heart. So you can tell about the size of the chambers, the way the chambers are contracting, relaxing, the valves allowing the blood flow around those chambers. You can tell pressures from the lungs, lots of information, very pain-free, very safely and reproducible. There's no x-rays, there's no radiation. It looks very much like a baby scan. It's that black and white image. We can do lots of other fancy things to it. There's lots of interesting things where we can do 3D studies, where it looks like a light is shining within the heart. Again, the world's your oyster, but it's real time. So what I see on my echo screen is happening there and then, and I will record a clip of it. We write the report from this. I will have somebody in, I will do their echo scan, I will measure and assess all of those structures in the heart, and I will give a diagnosis out to the doctor to say, this person has got ABC or XYZ. So I tell them what is wrong. It's up to the doctor then to put all of that together with what they read about the patient, what they hear from the patient, and what they're listening to the patient's chest, etc., and to put all together the treatment pathway for them. But this is just really one thing that cardiac scientists do. As I've mentioned, there's lots of other fun stuff that we do with cardiac imaging and with electrocardiography, but I'm just going to focus on the echo for this one. So for this one, I was asked to see a patient in intensive care. We tend to work pretty much multidisciplinary. Now, it doesn't matter where you work in the hospital, you will work with other disciplines, but that's what makes working in a hospital so fantastic. Yes, you have your area that you're expert and specialist in, but the communication that you have with everybody else needs to be incredibly open, transparent, and incredibly clear. And as a result, you have this beautiful, this homogenous working where everybody just is there for the right thing, and that's the patient. So we have to work well to each other. So I was asked to come and see a patient who is in intensive care. They'd actually come into the emergency department the day before, and they thought that this guy might have a blood clot on the legs or the lungs. He'd had a long haul flight, he's experienced chest discomfort. That was their working diagnosis. Overnight, he really deteriorated, got really confused to the point of becoming a little aggressive. We tried to do a CT scan of his brain, and actually, he really went south. His breathing became in trouble, his blood pressure dropped, and he was becoming very unwell. So intensive care got involved and got him upstairs, intubated and ventilated. So I've gone to see him. More because they're thinking something's not right with this guy. And if it is a blood clot on his lung, then actually an echo can tell us about the right side of the heart. So the side of the heart that's connected to the lungs. So more information was needed. But during the scan, this is what happened. So this is our initial picture. And I appreciate this is all just a little bit of crazy moving mess at the moment. However, you can see the heart rate there is reasonably decent. You can see it just at the bottom corner, the bottom right corner. And it's a little hard to understand, but trust me, there's something moving on the heart. There's something moving on the screen, sorry, and that is the heart. And actually, if I just trace around that image, like so, and then flip it, now it looks like a heart. You can see the top two bumps there of the atria and the little pointy bit, which is the bottom of the ventricles, the main pumping chambers of the heart. So just bear in mind, we're looking at the heart on its side. So I've kept scanning. Now, this is about my fourth picture into the scan, which is a matter of seconds. Something looks very, very different from the start here. The heart rate has dropped considerably. Where we started at 80 or 90, now we're dropping into 40 or 50. Actually, there's a lot less movement in that heart than there was at the start. So I've spoke to the guys that I'm with and said, guys, something has really changed with this. The heart rate's dropped, the heart function and squeeze has dropped. Can somebody check on the patient? Have we got an output? Now, what we mean by that is there a pulse? we can still have hearts looking like this and having a heart rate, but there's no pulse. So the heart's being quite inefficient. It's not generating a blood pressure to give you a pulse. So somebody has gone and checked for an output, a pulse, and there is none. So as I'm scanning this guy, his heart is pretty much stopped or about to stop. Now, if we do nothing at this point, I think we can all guess which way this is going to go. This patient is going to die in front of us with my probe on his chest. So this again builds back to the communication and team working. Instantly, we got on and provided CPR, so resuscitation to this gentleman. That involves a couple of things, usually injecting lots of drugs into the system and also doing chest compressions, so that when you're obviously beating hard and fast on the center of the chest, to try and get anything you can in terms of perfusion for this gentleman. So trying to get his blood out of his heart and into his major organs to keep him alive. So my next picture, now I know there's a little flash of blue color there, but can you see there's where that box is? There's lots of little speckles on that one side of the heart there. That's actually us. What we've done is we've injected something into this chap's vein, and you can just see the little speckles of that stuff. So that's all things that are in his blood supply that we've injected, and that's just them arriving in the heart. So you can see I've carried on scanning through all of this, because what I want to do is I want to be able to tell these people whether what we're doing is successful or not. And there we go, it was successful. The heart rate is right back up again, and you can see there's a lot more movement in that picture than there was a few pictures ago when it very nearly stopped. Now, there's lots of other things wrong with this gentleman. You know, if you're well into cardiology and well into medicine, we could go for hours on this and pick this out. And certainly this was a topic that I used for a conference this year, just because it was such a beautiful case of interdepartmental working being really crucial for a patient. But just I wanted you to take away that anything can happen with these patients. It's not a day in, day out job where every day is the same, very much not. But sometimes patients think, don't you ever get bored looking at hearts? Absolutely not, because this is exactly why I do my job. So great, what happened to this guy? Tell me it's a happy story, Emma. Absolutely, of course it is. We all needed a bit of a sit down after that. That was quite exciting. He was actually transferred as emergency over to our surgical centre in the next city along in Southampton. And actually, again, just to reinforce the multidisciplinary aspect of this, actually, I was on the phone to the surgeons at the time, telling them what I'm seeing, and he got transferred pretty much there and then, what we call a blue light transfer, so fire ambulance. And he did need to be resuscitated a further twice in that ambulance. He had his emergent surgery, and there was an abnormal structure in his heart, which they resolved, and it was that abnormal structure and a few other things which caused his arrest. He stayed in hospital for a few weeks, but actually he's doing great. And he had a follow-up about 12 weeks later back in my centre. And that is why we do this job. And I hope I've really sold it to you, just how this job is not day to day, how absolutely we all need to work together, and how actually we all need to be very much experts in the field. I'm not a surgeon, I am not a doctor, but I am expert enough in this field to know what diagnosis is going on with that heart and how to get the right treatment for that heart and speak to the right person.